I've been asked to talk a bit about biomarkers in urothelial cancer. It's really quite complicated. I think we've overcomplicated it. We'll start with the PD-L1 piece. There are 5 different ways of measuring PD-L1, 5 different biomarkers, and none of them have performed consistently, sadly, and actually none of them in a randomized trial have enriched to deliver a successful positive randomized phase 3. They are both inconsistent in terms of whether they're prognostic and predictive. And the 142 biomarker, for example, is a good example where second line in platinum refractory disease, it appears to be more prognostic. In frontline disease, it appears to be more predictive. And then in the adjuvant setting, it doesn't appear to work or enrich for responders, but it does appear to be a bit prognostic. So it's very difficult to, and that's the biomarker we know the most about. Other biomarkers, 22C3, we saw at ESMO 2020, we didn't see that biomarker enriching for response for single agent Pembro or for the chemotherapy combination, which was disappointing and partly contributed to the negativity of the study. So the PD-L1 biomarker is probably beginning to exhaust itself. Whether or not we can put PD-L1 with other biomarkers and make a sandwich of biomarkers to pull them together to increase enrichment is an important question, and TMB is the obvious partner to that. Actually, TMB has as many challenges as PD-L1. It looks from the back of the room, because you only see 1 or 2 PD-L1 presentations in bladder cancer, that everyone we see looks quite encouraging. But actually, when you look at the data in its entirety, it seems to be unsuccessful as often as it's successful. And of course, there are many different ways of measuring TMB. The mutation cut point, mutations per megabase, you can set at the median, you can set at 10, you can set at 7, at 9.6 in one of the trials. And clearly, if you change that, you're going to enrich for responses if you look if you try multiple times. You can also include different genes and exclude different genes, driver mutations, for example. And then finally, the different methods. Foundation 1 is one way of doing it with the gene panel. There's the Memorial Sloan Kettering way of measuring it. And then there's whole exome sequencing. So TMB seems to me to have as many challenges. And when you combine the two together, data from ESMO that hasn't repeated the data with atezolizumab, the evalimab data doesn't suggest this spectacular increase in enrichment. And my worry about this is TMB isn't adding much to PD-L1. So what about the next generation of biomarkers behind there? Well, we've seen CD8, we've seen T-effector gene signatures, and those signatures, those immune active signatures, look promising. The evalimab data presented at ESMO this year shows actually the innate and the adaptive immune system both appear to have a role to play. And that is suggesting to us a more complex picture than we initially thought. That's really important, because simply measuring PD-L1 or measuring CD8 or a single other signature probably isn't going to help us in the future. We're going to need to look at multiple biomarkers concurrently, and hoping to find one gene for success in the future is unlikely. We've also looked in that at the type of mutation that occurs, and it looks like actually different mutations result in different responses. We looked at the DDR signature, DNA damage repair signature, and that shows some enrichment. There's been work on that previously. There's obviously been some work also on TGF-β inducing resistance, which was reproduced again in the evalimab study. And then the last piece, I think, in the evalimab study, which is notable, was we managed to show in those T-cell active tumors, we managed to show angiogenic and notch signatures holding back responses. And so essentially, in summary, we've shown that the PD-L1 and the TMB story has not fulfilled as much as we hoped. We've moved on to a second generation of biomarkers. The story looks complex, which probably explains why PD-L1 and TMB on their own aren't good enough to get over the line. That complex story involves the innate and the adaptive immune system. We've also shown other signatures, TGF-β, notch, and angiogenesis, associated with holding back those responses. And so it is likely in the future, if we're going to select patients for immune therapy, we'll have to use multiple levels of biomarker. Thank you for your attention. I hope it's helped a little bit. I know it's confusing, and I hope you have a nice meeting.